Good morning, everybody. I just want to welcome you all to our session on how we treat post-transplant complications. I'm Jamie Locke. I'm a transplant surgeon. I have my clinical and academic home at NYU Langone Health, and recently, full disclosure, just joined as the Vice President for Medical Development for Xeno at United Therapeutics. But glad to be here today with my co-chair, Beatrice Concepcion. She's going to start us off. She's from the University of Chicago, and she's going to be presenting on management of common post-transplant complications, and particular how it relates to diabetic kidney disease. So, Beatrice.
Morning, everybody. Thanks for being here. Thanks for the opportunity to present. So I am going to be talking about how I treat post-transplant diabetes and diabetic kidney disease. I have no disclosures. And these are the learning objectives. Discuss the epidemiology and risk factors of post-transplant diabetes mellitus. Moving forward, I will just say PTDM. Recall the role of immunosuppression in the development of PTDM. Review current options for the treatment of diabetes in patients with kidney transplants, focusing on newer agents. So how do I treat PTDM and diabetic kidney disease? We will go through 6 kind of major points. 1 is education and counseling. 2 is screening and risk factor modification. 3, utilizing insulin and DPP-4 inhibitors when post-op or unstable. 4 is using GLP-1 RAs and SGLT2 inhibitors based on comorbidities. 5 is lifestyle interventions and other agents. And 6 is personalizing immunosuppression. So we'll start with a case. This is a 65-year-old man with end-stage kidney disease who comes to you for kidney transplant evaluation. He's on chronic dialysis. And he notes that his kidney disease is due to diabetes. He also has diabetic retinopathy and neuropathy. He was previously on insulin, but this was stopped 3 years ago due to hypoglycemic episodes. And he's currently maintained on semaglutide, 2 milligrams weekly. His current A1C is 5.5%, and other comorbidities are pretty common in our patient population. He's got preserved CHF with preserved ejection fraction, non-obstructive CAD, hypertension, hyperlipidemia, and his BMI is 35. So how I treat? First, we need to educate and counsel, and we should do it at time of evaluation and prior to transplant. So this is a very common occurrence. Patient comes to us for evaluation. They're no longer on insulin. Some of them will even say, I'm no longer a diabetic. My A1C is 5. I'm off insulin. And we all know that after transplant, these patients probably will require to come back on insulin, whether it's because they're now on immunosuppression or their kidney function has improved. And so I think setting expectations very early on about what to expect with their diabetes is very important. And PTDM and DKD are quite common, right? So a third of our patients have DM as their primary cause of ESKD, and almost half of patients on the waiting list have a diagnosis of diabetes. And as regards to post-transplant diabetes, there's about a 20 to 30% incidence, although that number is really controversial. There's quite varied reports, and most cases are diagnosed in the first 6 months post-transplant. So just reviewing that PTDM pathophysiology is multifaceted. There are pre-transplant risk factors, transplant-related factors. I will point out that probably the most important pre-transplant risk factor, because it's modifiable, is obesity. And why does diabetes occur post-transplant? Well, it's multifaceted, like I mentioned. There's reduction in insulin release, there's decreased gluconeogenesis, there's insulin resistance, urine creatine axis is dysregulated. And your brain is also dysregulated as about regulating your appetite and the like. And then I think importantly is that PTDM should be viewed in the context of cardio-kidney metabolic syndrome. So it's not really an isolation, but that there's other entities that you have to consider, and that they usually occur in the setting of not just diabetes, but hypertension, dyslipidemia, obesity. And in the setting of transplant, you have immunosuppressive medicines that increase risks of this metabolic syndrome, thus leading to increased risks for cardiovascular disease, cardiovascular death. And all that is related also to your allograft function, ultimately death, potential kidney transplant failure. And PTDM is associated with worse outcomes. On the graph on the left, you will see here that there's an increased risk of fatal and non-fatal cardiovascular events when you have diabetes post-transplant. It's worse in people who have pre-existing diabetes. Those who have new onset PTDM are somewhere in the middle, and the best outcomes are those who do not develop diabetes post-transplant. And then the figure on the right shows you that there's an increased risk of complications, whether it's microvascular or macrovascular. There's prolonged hospital stay, and there's increased risk of mortality. So back to the case, this patient received a living donor kidney transplant from his son. It was low immunologic risk with immediate graft function. Induction immunosuppression consisted of a bolus of methylprednisolone and a dose of alemtuzumab. And this patient was maintained on tacrolimus and mycophenolate with an early steroid withdrawal protocol. And on post-op day 1, not surprisingly, his blood sugars ranged from 258 to 451 milligrams per deciliter. So point number 2 is to screen and modify risk factors. Screen early and throughout the post-transplant course. Again, recognize risk factors, whether it's pre-transplant risk factors, transplant-related risk factors, and most importantly, I think, is weight gain. Post-transplant is quite common. Approximately 50% of patients gain weight after kidney transplant, an average about 10 to 35% of baseline weight in the first year after kidney transplant. And I put an asterisk there because, again, these figures can be varied depending on what paper you cite. So what is the diagnostic criteria of post-transplant diabetes? It's your standard diagnosis criteria that we're all used to: elevated fasting plasma glucose, an abnormal OGTT, and an A1C above 6.5% on 2 occasions. What I meant is OR. But recognize that A1C and fasting plasma glucose may have reduced sensitivity in our patient population. A1C, for example, is very difficult when patients are anemic. They might miss people who actually have abnormal glucose metabolism. And so, based on expert opinion, OGTT is really considered the gold standard for diagnosing post-transplant diabetes mellitus. However, it is not often utilized, and you can imagine why. Of course, it's more work for the patient. It's sometimes hard to organize, but it is the recommended screening modality. And so in 2022, the third international consensus on post-transplant diabetes mellitus was published. These were 18 experts who gathered in Vienna, Austria, who came up with some recommendations on screening and management. And I'm just showing you a figure here from the paper. But what it essentially tells you is that you need to continuously risk assess and do diagnostic screening. And so what are the time intervals that you want to screen using an OGTT ideally? You screen on the wait list so that you can identify risk factors to curb the incidence of post-transplant diabetes. You want to check sugars immediately after transplant. You want to do an early OGTT at 10 to 13 weeks, a late OGTT at 1 year and onwards, and then of course identify acquired post-transplant risk factors. All right, so moving on to point number 3, using insulin and DPP-4 inhibitors when post-op or unstable. You want to monitor and treat post-transplant hyperglycemia, and you want to use insulin or DPP-4s. So there's obviously a lot of factors that lead to post-transplant hyperglycemia, whether it's recovery of kidney function in people who already have pre-existing diabetes, but they are also subjected to corticosteroids, very high doses in the beginning, calcineurin inhibitors, and of course there's the pain, infection, and stress of surgery. All lead to hyperglycemia. So current evidence suggests that blood glucose target should be somewhere between 110 to 180 milligrams per deciliter because strict control leads to more hypoglycemia. Insulin or DPP-4 inhibitors are preferred, and really the DPP-4 inhibitors are preferred really for kind of lower risk of hypoglycemic events because other glucose-lowering medications do have this risk, especially with suboptimal kidney function. And this is a study I just want to highlight, which I thought is pretty interesting. This is a randomized trial looking at early post-operative basal insulin therapy versus standard of care to prevent diabetes mellitus after kidney transplant. So they enrolled 263 non-diabetic kidney transplant recipients, randomized them to the treatment arm versus a standard of care control arm. And I want you to focus on the lower two pie charts where you see patients who followed the protocol. There was increased incidence of PTDM in the control group as opposed to the treatment group. And again, focusing on the lower part of this panel, you see in the high-risk population that the hazard ratio for post-transplant diabetes was markedly reduced in the treatment group, 0.2. So the reason that I wanted you to focus on the lower part of the panel was because in the intention to treat group, the outcomes were not as significant, and that was because there was some non-adherence to the protocol. And so the conclusions of the authors were that early post-operative basal insulin administration has the potential to decrease sustained PTDM, but the therapeutic benefit depends on protocol adherence. So this intervention may be particularly beneficial in patients who are at higher risk of developing hyperglycemia. All right, so back to the case. On the patient's 1-month post-transplant clinic follow-up, he asks about resuming his GLP-1 receptor agonist. He is now on Lantus 35 units every evening, Novolog 10 units 3 times a day with meals and sliding scale insulin. And he notes that he has gained 20 pounds since transplant and his appetite is quote-unquote out of control. I think this is a very common scenario we see in clinic, quite predictable. And again, going back to point number 1, this is something that I think we should set expectations for patients that they shouldn't be surprised that this will occur. So point number 4 is using GLP-1 RAs and SGLT2 inhibitors based on comorbidities. And I'm going to spend a little bit more time on this section. So consider utilizing the new agents, and I want to take you through some recent literature that's been published on this topic. Understanding that the randomized control trials that showed benefit for SGLT2 inhibitors and GLP-1 RAs excluded kidney transplant recipients. So what we have here are retrospective studies as of now. So what is the real-world effectiveness of GLP-1 receptor agonists in kidney transplant recipients with diabetes? This was a study published by Orandi and colleagues. They looked at a USA-based retrospective cohort. They were able to link kidney transplant recipients with type 2 diabetes to Medicare claims, and so they limited the cohort to those with Medicare as primary insurance, a total of over 18,000 patients. And what did they find? In the primary cohort, you see here the reduced 5-year cumulative incidence of mortality in the group that received GLP-1 RAs. And then the adjusted hazard ratio and the adjusted subhazard ratio for mortality and graft loss respectively were also significant and pretty impressive. So they took it a step further. They did a matched cohort analysis based on survival time. So 1,969 patients on GLP-1 RAs matched to people who were not. And again, you see here the reduction in the 5-year cumulative incidence in those who received GLP-1 RAs. And similarly, and the adjusted analysis reduced hazard ratio for death and for graft loss. So conclusion of the study is that GLP-1 receptor agonists were associated with better graft and patient survival, and clinical trials are needed to confirm these findings. So just to summarize my take on GLP-1 RAs, I think definitely consider it for folks who have obesity and atherosclerotic cardiovascular disease. You have to be careful about the GI side effects, monitoring for that. Of course, we know the risk for medullary thyroid cancer and pancreatitis, so just sort of ensuring that your patient doesn't have those risks. And then thinking about sick day protocols, holding the drug when people are fasting and are having some GI issues, holding it pre-op as per anesthesia recommendations about a week prior to surgery. And then I think super important is to start at the lowest dose and titrate up slowly. And I was asked this question 2 days ago about CNI levels. It's not that the drug itself interacts with CNI, but it's just that when people start developing some side effects, they're nauseous, they have diarrhea, they're not eating as much, CNI levels tend to go up. So you really need to keep an eye on it as adjustments may be necessary. All right, so moving on to SGLT2 inhibitors, this is a study that looked at what is the efficacy of SGLT2 inhibitors among diabetic kidney transplant recipients in reducing mortality and cardiac and kidney adverse events. So this is a group that leveraged the international TriNetX database, which used aggregated data looking at kidney transplant recipients with diabetes from 2015 to 2023. And they identified patients who received SGLT2 inhibitors in the first 3 months post-transplant, and they used propensity score matching to compare outcomes. And the outcomes, this is a population of 26,834 without SGLT2, but you see the final number was 1,970 because this was a matched cohort. Similar in age, sex, race, ethnicity, comorbidities, medications, and laboratory results. And the outcomes were mortality, a composite outcome of major adverse cardiac events, and a composite of major adverse kidney events. And as you can see here again, in the SGLT2 inhibitor arm, there's significantly lower rates of mortality, MACE and MAKE, and that stood at the adjusted analysis. You see here the pretty impressive reduction in risk. So the conclusion of this study is findings indicate that SGLT2 inhibitor reduces mortality and adverse events in KTR, underscoring its potential to improve post-transplant outcomes. And then very briefly, I'll just show you a few more studies on SGLT2. This is another study out of Korea looking at 750 KTRs. Among them, about 17% were prescribed SGLT2. And again, here their MACE, adjusted hazard ratio was 0.3. Very impressive, though, in my opinion, is the MI, 0.04 hazard ratio. And importantly, they noted there was no difference in UTI rates between the two arms. All right, and then this is another study conducted in France looking at 347 kidney transplant recipients. And they were mainly initiated on SGLT2 inhibitors after the first year, and what they were looking for was discontinuation of the drug. So you see here the line in red represents the group with the lowest GFR strata, and those were the most likely to discontinue the drug. And then as far as adverse events, you'll see here that 17% were discontinued due to AKI, but importantly, UTIs and genital mycosis were pretty infrequent as a reason for discontinuation. In total, 15.6% of patients had the drug discontinued. So really not a whole lot. Majority of people were able to stay on the drug. So my take on SGLT2 inhibitors, it's good when good to start when kidney function is stable. The recommendation is 45 mLs per minute, but in a transplant patient these days, sometimes we don't really get to that GFR, and so you'd consider careful initiation even at lower GFRs. If patient has heart failure, I think it's a strong indication to start. You have to be wary of euglycemic diabetic ketoacidosis, and especially when patients are not eating, they're fasting, or they're sick. UTIs and genital mycotic infections are the side effects that are known, but in the transplant literature, nothing to suggest at this point that it increases risk. And then similar to GLP-1 RAs, having a sick day protocol is important. And then I think being aware of the hemodynamic effects of SGLT2 inhibitors, in that GFR might get reduced with initiation, and that kind of just hold steady. It's an expected reduction, and it's a hemodynamic effect. So knowing that, I think, is important. All right, so we'll go on to lifestyle interventions and other agents. So clearly, we need to encourage a healthy diet and exercise. Data suggests observational, it supports Mediterranean diets. I honestly had to look up what a Mediterranean diet is, so apologies to dietitians, but this is very important. I think you can't just tell a patient, do a Mediterranean diet. I think specifying what that is very important. And then there's also evidence that increased vegetable intake reduces post-transplant diabetes. And then as far as exercise, there is a randomized control trial that showed that a graded exercise program supervised by a dietitian lowered PTDM incidence as opposed to non-guided therapy. and higher physical activity is associated with lower risk of PTDM and cardiovascular and all-cause mortality. Okay. And then just looking at traditional agents, I want to highlight the study published in AJKD looking at metformin use and long-term clinical outcomes. So this is a study from Korea, retrospective, 6 centers, enrolled patients over a 19-year period, a total of 1,995. And majority were diabetic pre-transplant, but they did have a number who were diagnosed post-transplant. They looked at metformin usage and used the landmark analysis to address time-varying confounding. So what their key findings were that there was no difference in all-cause mortality, but there was a benefit and after adjustment for the hazard ratio of death-censored graft survival. So not quite sure exactly kind of what the hypothesis is, but that is a benefit seen in the study. There was no difference in acute rejection. The other thing they looked at was the lactic acidosis events, and they had 77 events. So I think very minimal for the number of patients in the study, and none of them were attributed to metformin use. So the conclusion of the authors was that metformin usage may benefit KTRs as evidenced by its association with the reduced risk of dense or graft loss and absence of metformin-associated lactic acidosis events. So my take here is that it's a pretty safe drug to use. If you don't have, strong indication for other drugs, it is an option. And then, of course, thinking about accessibility of a drug, metformin is quite an accessible drug. So I think you can feel good about using it in patients who are appropriate. All right, so let's go back to the case. On the patient's 3-month post-transplant clinic follow-up, he is doing well. He is on Lantus 20 units every evening, so his dose has been reduced. He's now on semaglutide, which was started 2 months prior at 0.25 milligrams weekly and ultimately up-titrated to 2 milligrams weekly. His serum creatinine is 1.1, his A1C is 6.7. He has minimal proteinuria, 0.25 grams per gram. So the question is, can he be optimized further? So I just want to put it all together. I've shown you a lot of studies and a lot of data. So what do? This is from the third international consensus of post-transplant diabetes mellitus, which I showed you earlier, the citation. So you need to initiate glucose-lowering treatment for post-operative hyperglycemia. Your options are really going to be insulin or DPP-4 inhibitors. And so when there is persistent hyperglycemia and the patient's now on a stable immunosuppressive regimen, you move on to outpatient management where you really want to personalize glucose-lowering treatment. And what does that mean? So you want to look at, general recommendation. What are the comorbidities? Do they have CKD, heart failure, atherosclerotic cardiovascular disease, obesity? What is their graft function looking like? What is their overall condition? And at least based on this consensus recommendation, anybody you can consider metformin, SGLT2 inhibitor, GLP-1 receptor agonist, DPP-4Is. So the asterisk there is just a reminder about the sick day protocol where patients know when to hold the drug when they're not feeling well, they're not eating, and the like. So I think the DPP-4 inhibitors is safe. It does show, some glucose-lowering effect, although not robust, but it really doesn't provide you any cardiovascular or renal benefits. And I think the authors of this consensus recommendation do feel strongly that SGLT2 inhibitors and GLP-1 receptor agonists should be prioritized when there is no issue with access. So we know that access can be a problem. It might vary in different parts of the world, but it can be prioritized. For those with CKD and heart failure, SGLT2 inhibitors are recommended. For those with obesity and or established ASCVD, GLP-1 receptor agonists should be considered. And if there is instability, so graft function is unstable, there's an AKI, graft function is suboptimal, patient's overall condition is suboptimal, or they're post-op, immediately post-transplanted insulin. And then adding insulin, I think, to all these regimens when necessary is obviously a next step. And what I forgot and important to note is that everybody should have lifestyle and dietary recommendations. All right, so the last part of my talk is point number 6, which is personalizing immunosuppression. So weigh the metabolic benefits of your immunosuppressive regimen with the risks of rejection. So we know that immunosuppressants contribute to hyperglycemia through several mechanisms. Calcineurin inhibitors reduce insulin transcription and secretion by pancreatic beta cells. Corticosteroids cause weight gain, insulin resistance, and increased gluconeogenesis. So what are your strategies that you could potentially think about? Can you switch tacro to cyclosporin? Can you switch the CNI to perhaps a low-dose CNI mTOR regimen, similar to what, if you're familiar with the Transform trial, is what they did. Could you withdraw corticosteroids, or could you switch CNIs to belatacept? So I'm not going to spend too much time on number 4. There is some data there to say that there is less PTDM with belatacept. Belatacept's not known to cause any metabolic effects, but really studies have not been geared looking at that outcome, and it's very important that in future studies that's actually looked at as a primary endpoint. So looking at switching tacro to cyclosporin, I'm citing here a relatively older study from 2007, which is the DIRECT trial. And what they found was that there was more impaired fasting glucose and PTDM with tacro compared to cyclosporin. I don't think that's a surprise to any of us who have used both of these drugs. So the incidence at 6 months was 26% versus 33.6% in the tacro group. This is a relatively recent study published in Kidney Medicine looking at which immunosuppression regimen has a lower risk of PTDM. It was a retrospective database study looking at USRDS and OPTN, kidney-only transplant recipients. This is a US-based study and enrolled patients from 2005 to 2016. Their outcome was development of PTDM and looked at the predictors of immunosuppression, age, and weight. And what did they find? So the incidence of PTDM greater than 3 months to 1 year was higher in older individuals as opposed to younger individuals, and those with higher BMIs above or greater, equal or greater than 30 as opposed to less than 30. So they looked at varying immunosuppressive regimens, and what they found was that those induced with thymoglobulin or alemtuzumab with steroid avoidance had a reduced hazard ratio for developing PTDM as opposed to those who were maintained on steroids. And you can see here that the effect is a little varied based on age and based on BMI. For those who got induced with basiliximab with steroid avoidance, it was only beneficial for older patients. So the conclusion of the authors was that the beneficial impact of steroid avoidance using TAC on PTDM appears to differ by patient age and induction regimen. Okay, and then probably the last study I'll present is the Allegro study, which was published a year ago, asking the question, can immunosuppression minimization strategies result in similar kidney function? So looking at outcomes of not just metabolic effects, but also kidney function. This was an open-label, prospective study, multi-center, randomized, controlled. This was done in the Netherlands in 3 centers, enrolled 295 patients from living or deceased kidney donors with low to medium immunologic risk. They were randomized. This was a non-inferiority trial. So the different induction regimens were, well, they were all induced with basiliximab and steroids. A standard of care was a 3-drug regimen of tacro, extended release, MPA, and prednisone, lowered to 7.5 milligrams daily. There's an early steroid withdrawal protocol where there's no steroids after 3 days, and a tacrolimus minimization protocol with a trough goal of 3 to 5 from 6 months post-transplant. And what you see here is that in the non-inferiority portion of this, the kidney function in all 3 groups were about the same. But what you see in the early steroid withdrawal is a higher incidence of treated rejection, although the incidence of diabetes post-transplant was lower, right? So this just tells you what is the trade-off of doing something like withdrawing steroids early. Well, you trade off rejection with reduction in diabetes. And to note that tacrolimus minimization arm, similar to the Transform trial, didn't really show any difference in diabetes rates, rejection rates, or eGFR at 24 months. So the conclusion of the authors here is that immunosuppression minimization regimens result in similar kidney transplant function. Before withdrawing steroids, risk of rejection should be weighed against potential metabolic advantages. All right, so on the patient's 12-month post-transplant clinic, he's doing well. He's on Lantus, semaglutide, dapagliflozin. Serum creatinine is 1.3, his A1C is 6.2, he has no proteinuria, he's lost some weight. Really great. So again, to summarize, it's perfect patient. I wish everybody was like this. But again, the 6 points, just to remind you what we discussed today. And to summarize, post-transplant diabetes and diabetic kidney disease are common and associated with worse outcomes. Early diagnosis and intervention are important. Management, including immunosuppression modification, should be based on the patient's clinical and risk profile. And retrospective studies suggest benefits from GLP-1 RAs and SGLT2 inhibitors. So with that, I'm going to end my talk. Thank you so much for your attention. This is my email. You can feel free to take a picture. If you have any questions, I'm happy to answer at the end of the session. Okay, so now I have the pleasure to introduce our next speaker. It is Dr. Ann Woolley, who is a transplant infectious disease specialist at the Brigham and Women's Hospital here in Boston. Thank you, Dr. Woolley, for joining us.
Good morning. Thank you all so much for having me here today. And I was given the challenge of saying, how do I treat post-transplant infections? It's a bit broad. So what I thought I would do, given the room of mainly nephrologists, I would imagine that I would focus more on the more atypical or things that are very much ones that we work in collaboration with for infections, rather than some of the more standard ones. So the learning objectives for mine is to really articulate the evidence-based strategies to manage post-transplant infections. And so we'll talk about the fundamental principles of infections and renal transplant recipients, what's the timing of infections post-transplant, the role of prophylaxis versus empiric versus preemptive treatment. We'll talk about donor-derived infections and what the implications of that would be, and then other post-transplant infections. We won't cover all of them, but I'll highlight a few. So back in the 90s, we know that indication for hospitalization post-abdominal organ transplant mainly was due to infection over rejection. But then fortunately, in the first 10 years of 2000, the deaths due to infectious complications in our transplant patients decreased. You see the line in blue being kidneys. However, though we've made such advancements in the early 2000s, really with antifungal treatments, antiviral treatments, and other antibiotics, we still have significant comorbidities and infectious and non-infectious sequelae from infections in our renal transplant recipients. So this was a paper from 2020 showing the clinical impact of infection on our renal transplant recipients. So you see, with the exception of the cardiac events, and here each graph here is labeled red for those recipients who did not have infection, compared to blue, those renal transplant patients with infection. And you see for rejection, graft loss, and all-cause mortality, those patients with infection did worse. So why is this? Well, we know that diagnosing and treating infections in our non-HIV immunocompromised patients is quite challenging. And the reason I qualify that for the non-HIV is because we still don't have a good marker, a good biomarker, a good sense to really be able to risk stratify a patient to say, why is patient A, who's undergone a renal transplant on similar immunosuppression compared to renal patient B, more at risk for infections and having worse outcomes from infections. Unlike in our HIV patients, when we have a CD4 count, which we know is very, very helpful in really knowing what their risk for opportunistic infections is. So we know that infectious differential is broad, the clinical manifestations are often atypical, and our diagnostic tests, though fortunately improving, particularly in the past 5 years and now with more metagenomic testing, it's still insensitive, or it's very sensitive and low specificity. And the turnaround time for these tests, as you all well know, when we say, we'll get back to you next week, is quite long. Treatments are not without their toxicities, and obviously we always deal with drug-to-drug interactions. So the fundamental principles of infectious diseases in our transplant patients really relies on the fact that the onset of disease depends on the interplay between the host, the pathogen, the environment, and the host microbiome. Host susceptibility mainly depends on genetic factors and one's immune status. The main factor for successful colonization of the host tissues by the pathogen is its virulence, meaning that there's so many different parts to this. So how could we be able to very easily capsulize in one patient what their risks are? But this is why I find this so interesting and why there's not really a great algorithm on how to treat all of our renal transplant patients, and it really needs to be very individualized. So just to build on this, when we think about ID, the environmental exposures or the inoculum, times of virulence, over the net state of immunosuppression, because that's really what we're trying to get at here. What are the underlying conditions, the anatomic, technical defects, what immunosuppressive treatment is a patient on, anti-inflammatory treatments, and targeted immunomodulators. This is what really impacts, and it's that interplay between the pathogen and the host, which really drives us in thinking about what is the virulence, what is the severity of infection, how should we treat it, and what are the outcomes. So just to frame this discussion, using immunosuppressive regimens that you all are well familiar with, I want to highlight these in regards to what we think about in terms of the infectious risks. So if we start with corticosteroids, we know they broadly impair our immune function. They suppress phagocyte function, reduce antigen presentation. They inhibit NFKB activation, which decreases cytokine expression and T-cell proliferation. And they ultimately impair wound healing and skin integrity. So therefore, that comes with it bacterial infections, opportunistic infections like pneumocystis, invasive fungal infections, and reactivation of latent viruses. Alkylcarnitine inhibitors, such as cyclosporin and tacrolimus, inhibit our IL-2 transcription, leading to T-cell suppression, impairing our cell-mediated immunity. This, therefore, increases our risk of viral infections, especially CMV and BK virus. And the reason I highlight this is that I always think about this in terms of how I risk stratify the patients. And when we talk together with our transplant colleagues as far as asking, it's not just about decreased immunosuppression. It's really about saying, what is it that we're worried about? In a patient with CMV, I'm very cautious and always asking, can we decrease their cyclosporin or whatever they might be on because of that specific risk, as well as their antimetabolites. Because the antimetabolites inhibit purine synthesis, targeting lymphocyte proliferation. This leads to leukopenia and many of our patients neutropenia. So this also causes an increased risk of viral infections, as well as some bacterial infections, and also GI infections. And I think this is a subtle point that we see, is due to mucosal breakdown, such as C. difficile, we might see a little bit higher in the patients on this. And then our mTOR inhibitors. So they impair cell proliferation, wound healing, endothelial recovery. There's also, as I'll get to later in the talk, they may have some antiviral properties, but they also suppress the innate immunity, therefore impairing wound healing, dehiscence-related infections, mouth ulcers that you might get that can then serve as an entry point for pathogens. It's less of a CMV risk compared to MMF because of this theoretical and some emerging data to suggest that it has antiviral properties, but it can worsen viral infections if combined with other agents. And then belatacept inhibits CD80-86 interaction with CD28 on T cells, therefore blocking T cell activation. This can increase someone's risk of PTLD, especially in our EBV mismatch patients, as well as increasing CMV and other viral infections. And then the ones that we all love the most when we think about what are how high a risk are our patients. If they've gotten thymoglobulin or alemtuzumab, we know that has profound and prolonged lymphocyte depletion. And these effects can last months and to over a year in many of our patients. And so the severe infection risks for these patients that have been on this really vary the gamut. And I think we often forget this. And I bring this up in one of the cases later on in the sense of this is often given as induction. And then 4 months later, we're dealing with a patient and not thinking that what they got in terms of having gotten ATG is really, or thymo is really impacting then why we can't clear, for example, their CMV reactivation. So we've all seen this in terms of the timeline of infections post-transplant, but just as a reminder, the first 6 months, really thinking in terms of our opportunistic infections around 6 weeks to 6 months as compared to the first 6 weeks, thinking about the nosocomial, any surgical, technical, or donor-derived infections, and then after 6 months, community-acquired infections. We know that can occur right after a patient goes home as well, but more likely when we have patients later on in their post-transplant course needing to think about the same infections that any of our non-immunosuppressed patients are at risk for. But really, when we think about all these, the nosocomial, technical, the activation of latent infections, relapse, residual, opportunistic infections, and a community-acquired, it's really a dynamic assessment of the infectious risks. And it's one of these that is not at all, you turn this page at 6 months, and then you can forget about the fact of certain things. We know that pneumocystis, for example, has a bimodal distribution. So we think about that earlier on, and then you think about late pneumocystis. And these are often the things that are much harder to diagnose because we're not thinking about them as much, because we think, well, this renal transplant patient is now 7 years out, doing well. Maybe it's just a regular community-acquired pneumonia, and then it's multiple admissions, multiple things that don't look right, and then delayed diagnosis in pneumocystis. So you might be sitting there and saying, well, that's why we ask everyone on our ID teams just to give all our antibiotics, give all antivirals, all antifungals. Why not just blanket our patients with this? Well, we know that the effect of antimicrobial prophylaxis on the rate has a significant impact on the rate of and the time to infection, but it doesn't eliminate this. So my mentor, Lindsay Baden, published on this in 2005, showing that all you're really doing is moving the pendulum. You're just saying when that infection may occur when you put on prophylaxis. You're not absolving the patient from getting anything. You're not saying, okay, we're just going to forget about CMV because that's why we're going to give you prophylaxis. We're saying that we're going to minimize your risk of getting it in this period of time because you're at highest risk for getting complications from it, and then we'll deal with it later on. But for those centers, as we know, particularly we see it more in our lung transplant recipients that get antifungals just indefinitely, they still have fungal infections. It may just be later, and it may just be more resistant infections at that time. So it's really important for us to think about which patient groups during what specific time frame have a high enough attack rate for the patient to benefit from prophylaxis. Unfortunately, in ID, we only have a few things that we can really hang our hat on with this. And one of them is an old study from the 1960s that showed us that neutropenia is a true risk factor for infection. And when you cross that line and getting less than 500 neutrophils, that is when you significantly have an increased risk of infection. And then similar from that paper showing the risk of Aspergillus infection, again, being so dependent on your neutrophil count. But other than that, we don't really have much more to go on. And even with this, these data are really in the fact of when they're getting hematologic malignancy patients that are being treated with chemotherapy that then leads to this. We like to extrapolate it, and we all get very nervous when we have a renal transplant patient with an ANC of 300. But the data don't support the fact that this exactly can be transferred to that. We know the principle is similar, but it's not exactly, so we have to take it with a grain of salt as well. So now going to donor-derived infections. So when we think about all our different donor-derived infections, we'll talk some about bacterial infections and parasitic infections for some cases, as well as viral infections. So this is a donor. It's a young woman with a coma who presented with fever, stupor, and double vision. She had a cavernous sinus thrombosis, a jugular thrombophlebitis, cerebritis, and ventriculitis. She was intubated upon admission. She had an LP that showed a significantly elevated opening pressure of 60, 1,000 total nucleated cells. She was empirically treated with vancomycin and meropenem, had heparin drip, hyperosmolar therapy, was not seen to be an EBD candidate, and had refractory cerebral edema. 72 hours after admission, 2 out of 4 blood culture bottles that have been drawn grew gram-negative anaerobic rods that you can see here in the gram stain, because it wouldn't be an ID talk if I didn't show you at least one gram stain. And then after it grew at 72 hours, then it was speciated 2 days after that for Fusobacterium. We know that Fusobacterium can lead to this Lemierre syndrome, causes pharyngitis, a deep neck space infection, and septic jugular thrombophlebitis. This was an otherwise healthy young woman who had a very severe manifestation of this, ultimately leading to her death. Can this patient be a donor? Would you accept organs from this donor? So I would argue yes. I think this patient is a suitable organ donor. What it comes down to is donor management. In my role with our OPO here in the New England region, we manage these donors and say, we think about donor management from every other aspect, but often we forget the ID part of it. And so fortunately, since we had some time, we took into 3 more days to make sure the donor was appropriately treated, had appropriate workup, no vegetations on echo, did not have any septic pulmonary emboli, somehow fortuitously, very nicely, and no abscess, infarct, septic emboli, abdominal organs. Therefore, the heart, lung, both kidneys, and the liver were able to be successfully allocated, and all of those recipients are doing quite well, the heart and kidney at our center. And what this really comes down to is how do we manage both the donor and how do we manage the recipient? So the donor had been on meropenem for this. Our recipients, we treated with ceftriaxone and metronidazole, and we treated for 10 days post-transplant. In the heart recipient, we did 14 days. In our kidney, we did 10 days. And I mention this to say we're so commonly, when we think about donor-derived infections, we think about it as an absolute. Would you accept this donor, yes or no? As compared to, from an infectious standpoint-wise, compared to, would you accept this donor if we could manage the donor a certain way and we can manage the recipient a certain way? And I think that's the key. Because often when we talk about donor-derived infections, we think about the high morbidity and mortality, which we know exist. But the overall number of cases is actually quite small. It's less than 1% of deceased donor transplants. But that percentage and that number is based on unexpected. So it's not, so the one example I showed you, if a recipient had gotten bacteremic or whatnot, it still would have been reported and would have come into this, but I don't think it's the same way because it wouldn't be unexpected. It's the fact when we don't know things that are going on in the donor and then we are surprised with this in the recipient that's much harder. So how do we track this overall? So the Disease Transmission Advisory Council, as part of the OPTN, looks at proven and probable donor-derived infections that all the centers submit. So if we look at this in the categories, and this is Dan Call published on this data back in 2021, for the first 10 years, DTAC had been in existence with all the cases that had been proposed to DTAC and adjudicated. And you see that the highest proportion in terms of the different infectious groups was viral and bacterial. Less so, just 22% of cases fungal, very few mycobacterial, and 12% parasitic. Overall, in that 10-year or that 2008 to 2017 timeframe, there were 250 cases of donor-derived transmissions from 244 donors. So going a little bit more and seeing what about the kidney recipients. So when you look about the number of donors with transmission, but then thinking about the number of recipients, knowing the different number of organs that are transplanted from the donors, and how does that compare overall with kidneys? And what about the transmission-related deaths? So we know that the transmission-related deaths are much higher out of proportion to the number of overall small number of cases that actually have donor-derived transmissions. And fortunately, in our kidney recipients, overall for all the categories, viral, with exception of bacterial, viral, fungal, mycobacterial, definitely, and parasitic, it's a lower proportion than our kidney recipients. So in a donor that may have transmitted a certain infection to the lungs, the liver, the heart, kidneys, with the exception of bacterial infections, are less likely to be one of those. So what's the framework I use for accepting infected donors? It's really understanding the risks of possible transmission. Is it a known infection, or does a donor just have risk factors? Is the infection preventable or treatable? What are the complications, both the infectious and the non-infectious sequelae? And then can we mitigate the risk? We have improved diagnostics for both donor and recipient testing. And then we need to think about the interventions to reduce the incidence and severity of disease. But ultimately, as we know, it's a case-by-case risk-benefit analysis. However, again, this is for unexpected donor infections. That's what leads to the challenges. But if we think about this as far as the expected known donor infections, then this really gives us opportunities to expand the donor pool and increase organ utilization if we're willing to think about how we can treat our recipients with known infections in our donors. This is what we've done with hepatitis C since 2017. This is what we've done and continue to do with CMV and many, many other infections. So if you put this checkerboard here of 12 different conditions, infections that donors may have, which of these do we think would be safe to accept a kidney from? Because it's also not just is the donor okay, but which organ would you be okay to accept from a donor with these different infections? Bacteremic, bacterial meningitis, meningoencephalitis, cocci, Chagas, aspergillus, COVID-19, flu, HSV encephalitis, Hep C, hepatitis B, HIV, triple E, or encephalitis of unknown cause. And I would propose that all of these, with the exception of triple E and encephalitis of unknown cause, which gives me the biggest concern, because we don't know what it is, and therefore we can't treat the donor or the recipient correctly. Same with triple E. For the other cases, we should be able to, on a case-by-case basis, treat the donor and/or treat the recipient to be able to mitigate these risks. We know, though, just a word about the arthropod-borne flaviviruses. I don't want to leave with the standpoint that we can be cavalier with these. And we know with West Nile, dengue, and these other viruses that the infections that are associated with high mortality and morbidity in our recipients, if they acquire them after transplant, and particularly if they're donor-derived infections. And so that's why it's so important for us to manage the donor and ask our OPOs to the questions of why this donor died, to make sure we feel comfortable that we have a cause rather than worry that we're missing one of these other infectious causes of encephalitis. So now on to another case. A 73-year-old gentleman that had a renal transplant 7 weeks prior, who was admitted from clinic with left lower extremity pain and edema, found to have a DVT, had been complaining of progressive dyspnea for the prior 2 weeks, and also had watery diarrhea, poor appetite, a 6-pound weight loss since transplant, and crampy abdominal pain. No fevers, night sweats, or bloody stools. The dose of immunosuppression, MMF, had been decreased the week prior. His CT chest was notable for diffuse tree and bud and ground glass, central lobular nodular opacities in the right lung. And then on exam, it was notable for a periumbilical petechiae purpuric rash. We know that this is a Thumbrand sign, and the skin biopsy showed us filariform larvae of strongyloides between the collagen bundles in the dermis. And then it was very dramatic, this case, because on sputum, as well as in the stool, you saw the rubidiform larvae. So this was strongyloides in our renal transplant recipient. We know that the hyperinfection syndrome was first reported in The Lancet in 1971 and has a fatality rate of more than 50% in immunocompromised hosts. Donor-derived strongyloides was first reported in a renal transplant patient in 2007, and then first reported in a lung transplant recipient was in 2009. I bring this up because we were able to manage this recipient successfully. We used ivermectin and then acquired approval to be able to get ivermectin IV from our veterinarian supply from it locally here in Boston. And it was very challenging because the patient was quite sick for a month, but the patient ultimately did well. But what was the issue here? The issue was we didn't know, because this donor was from a region outside of our area that does not routinely do strongyloides testing on their donors. And based on the DRE, they didn't have any obvious risk factors for strongy. It wasn't from what we consider the high-risk endemic areas. But unfortunately, we know strongy, as well as so many of our fungal infections, those historically where they're more at risk for has really grown the gamut. And now almost the majority of places in the US now, you can have risk for acquiring strongyloides, and therefore we have to be thinking about this and really should be thinking, which has now been proposed and approved, to have universal donor testing for strongyloides. It just hasn't yet been put into effect. So really this comes down to the stewardship of our OPOs to identify the risk of transmissible infection from the deceased donor while maximizing the utilization of organs. How do we do that? We know that this is all the required testing that we get on all of our donors, but then we have this optional additional testing. And now strongyloides has been proposed and, as I mentioned, approved. So this will start to take effect once, with everything that's going on right now and all the issues with the OPTN as far as being able to put this into effect, but at least that will be. As well as with Chagas, that will also be required not for all donors, but for those that do meet the risk factors from endemic areas, that will be required of OPOs to do. So I think this is really critical when we think about how we treat our recipients, because not only does it expand the donor pool of of where we should feel more comfortable accepting these organs. But then if we know that our donor had strongyloides, had Chagas, it doesn't mean we have to decline those donors. Instead, we can appropriately know how to treat our recipients. So another way to think about the timeline of infections, if we think about within the first 30 days, we think about those early post-kidney transplant infections that are usually healthcare-associated infections somehow. And then within the first 12 months, those opportunistic infections, and then afterwards. But I think the important thing throughout all of this is that we can see our friendly virus, CMV, at all different points. So let me take a case here. A 61-year-old woman with a history of IgA nephropathy underwent a renal transplant 8 months prior with CMV D plus R minus, came in with diarrhea, abdominal pain, fevers, and malaise. Had completed the valsite prophylaxis about 2 months prior, had no recent episodes of rejection, stable immunosuppression, MMF, TAC, prednisone 5 milligrams. The most likely cause of her diarrhea and other symptoms, CMV colitis, MMF-induced colitis, norovirus, salmonella. Well, this patient had CMV colitis, which was very classic. The workup included a serum viral load of 88,000, underwent a flex sig with colon biopsy, and the path, as you can see there, was consistent with CMV colitis with the inclusion bodies. Was treated initially with IV GAN, given concern for poor absorption, and then switched to oral valganciclovir. And I highlight this because they didn't need IV GAN. We do not need to do IV GAN for induction, which is often the thought of it. It's about absorption. If we think a patient is absorbing meds okay, but if they're having significant GI illness from CMV, that's the reason to use IV GAN. But then pretty quickly, this patient was able to be switched to oral valsite and treated as an outpatient. Another case, a renal transplant patient from 8 months prior, came in with a very similar chief complaint, and pertinent post-transplant history, also very similar with the exception of having ACR 4 months prior, for which the patient received a steroid pulse. So the differential diagnostic workup for this patient included all of these things, and this was a patient that had both CMV with a peripheral viral load of 13,000, underwent a phleg, sigmoid, and colon biopsy, which showed apoptotic crypt epithelial cells consistent with mycophenolate-associated mucosal injury. No CMV viral cytopathic changes were seen. So what does this remind us of? That Occam's razor does not always apply to our transplant patients, and that really now we have to be thinking about often here a razor that has more than one blade, and that we can't just anchor, because we have, how many times have we all made that error where we think, oh, like the first case, it's obvious, CMV, and we go that way, but then symptomatically they don't improve, and then we've missed the diagnosis. And so really thinking how important diagnostics are, though we're focusing on treatment in this talk, we can't talk about treatment without diagnostics, because then it really puts us at a disadvantage by empirically guessing and therefore treating. So now another case with CMV, getting to much more of the challenges with CMV in terms of resistant refractory infection. So this was a 58-year-old that had donor-derived CMV by virtue of the fact that donor and recipient were seronegative, but then on recheck of the donor testing after the recipient had detectable CMV, was shown to have a very low level viral load. Patient also had BK viremia. So overall, I won't go into all the details due to timing of all the case, but the patient had a very high viral load, which is seen in blue. And then you see also the BK, and you see the ANC, and then in yellow, the treatment, and then below, the immunosuppression. So this was a patient that got an ATG for induction. Was doing well on valsite, came down on immunosuppression, but really continued to have these very low ANCs despite getting GCSF. So then eventually was switched, this is now many months into it, to marivir. And so now we think, great, we have more treatment for CMV, an oral regimen, is this the panacea? And unfortunately, as we've all seen and are seeing more and more cases, this is not a panacea. So when we think about CMV in our transplant recipients, we have to think about more than just the infectious risks, because there is many effects of CMV outside of that. And so we know that it increases our fungal bacterial superinfections, mortality, and can decrease graft function. We know the risk is greatest in those with a D plus R minus, but we can't forget about the D minus R minus and make sure that we check a CMV viral load 2 to 4 weeks after transplant, because that's how you can have donor-derived CMV unknowingly. We know that the risk factors for CMV reactivation is fortunately, much lower in our renal transplant patients compared to other organs, but ultimately it comes down to that net state of immunosuppression that we talked about initially. And then we know centers do different things in terms of preemptive therapy versus antiviral prophylaxis for an extended period of time versus a mix, short course of antiviral and then a short course of doing preemptive with frequent CMV viral load. Well, the jury's still out on which is better. Many centers do a hybrid. We know that there's pluses and minuses with both. And there's many studies that are being used to look at, is there a benefit? And so we have some colleagues that truly believe that universal prophylaxis is not as good. And there was this study that was published in JAMA in 2020 by Nina Singh that showed that actually in CMV D plus R minus liver transplant recipients, the use of preemptive therapy compared with blanketing antiviral prophylaxis resulted in a lower incidence of CMV disease over 12 months. And perhaps this was because the antiviral prophylaxis actually led to suboptimal CMV-specific immunity, and therefore that was worse than impairing the CD8 and CD4 T cell responses. The jury's still out. I'm still a fan of prophylaxis for a shortened period of time in both our thoracic and our abdominal organ transplant recipients, because I think that we're not just looking at the academic effects of overall what's happening and just low-level CMV, this doesn't matter, but as fact of when we lose control, like in this patient, it can be very difficult, both for morbidity, graft function, et cetera. Fortunately now, as you're all aware, we have letermovir, so we have an option, and we don't just have to have all our patients on Valcyte, which is so bone marrow suppressive, and instead now published in 2023, showing that letermovir is non-inferior to Valcyte in terms of prophylaxis, but letermovir is not for treatment. It has a very low barrier to resistance. So the different guidelines in terms of for those centers who do prophylaxis really varies by organ type, by CMV donor mismatch, and also whether or not you are doing the 6 months versus 3 months varies by many centers. This is what is recommended overall, but as you see, there's ranges because we don't know. There's no good data on this. We're just changing the pendulum. But for resistant and refractory CMV, fortunately, it happens very infrequently, but when it does happen, the consequences are very significant, leading to increased mortality, increased graft loss, and significantly having these patients in the hospital for months at a time sometimes. The risk factors for this is really a lack of CMV-specific immunity, antiviral drug exposure, and ultimately what we see in our renal transplant patients is suboptimal drug concentrations. When our patients are having fluctuating renal function, then often it becomes very challenging to be able to know how to dose the Valcyte accordingly. And those are often why I like letermovir in those cases too, because then you don't have that difficulty with dosing them. But those are the patients that we have issues with. I won't go into all the specifics of all the different gene mutations, but I put this up here just to remind us that we do know how to be able to tailor this. However, it is very daunting. Once we get a patient that we have to do CMV resistance testing on, you know we already are down that pathway of requiring more toxicity from additional antivirals that will need to be used, often a hospitalization, and often long-term issues with graft function as well. The outcomes overall in patients with resistant CMV, even those that are successfully treated, have a worse morbidity and an increased 3-month and 1-year mortality in those patients that have ganciclovir-resistant CMV. So I think that's very important to know. Though we can treat, though we can turn it off, we know the outcomes are worse. We have cidofovir, has renal toxicity, foscarnet, we know renal and metabolic toxicities. And unfortunately, we thought marivivir was going to be that answer. And it's helped. And it can help many patients because it does not have the toxicities. However, it does have poor CNS penetration and a very low barrier to resistance. Ultimately, we want to make sure if you're switching a patient to marivivir, that patient has a very low viral load when you switch it to. And that's what the data has shown. So in the Solstice trial, and I'm sorry I'm going quickly through this, I want to put this up there to just show that where we have the data for ID, since there are a lot of areas we don't have data, but not to get into this granularity of it right now, but just to say that from the Solstice trial, what we learned was not only was marivivir had a safer profile compared to ganciclovir and foscarnet, but we did learn that the viral mutations appeared after several weeks of being on marivivir treatment, and their detection required a wider scope of UL97 genotypic testing testing. And so in here, it showed that if you had a viral load less than 10,000, you were more likely to not develop resistance to marivir. However, I've had multiple patients that have had low viral loads of less than 3,000, less than 2,000. Even this patient that we'll get back to that had a viral load of only 700 that goes on to develop resistance. And then I mentioned in the beginning when we talked about immunosuppression, about mTOR inhibitors and how the fact that that can be having some antiviral activity as part of it. But this is still a bit academic. And I think when we're really struggling, like we were in our patient here, we did say, well, we're really getting out of options. So we need to do something because the patient was not going to be on any immunosuppression. And we know that CMV in and of itself can lead to resistance. And so therefore, we did put the patient on an mTOR inhibitor and eventually, finally with foscarnet, was able to bring the viral load down and then switched him to letermovir. And we were able to control CMV, but unfortunately he lost his graft. But surprisingly, it was not due to CMV. It ultimately was due to BK. So we know that interplay between the two is so critical. So in conclusion for CMV, we know that resistant refractory CMV represents a major therapeutic challenge and new, safe, and effective treatment options are necessary. And risk factors for CMV resistance we have to think about before it happens to minimize that. And the biggest thing that we can do to really mitigate that is making sure we don't have suboptimal doses of the valsite for prophylaxis. And marivir is a great advancement. Don't get me wrong, but it's not the end of the story. It's not our panacea. We are out of time, so I just want to highlight the other ones without going into details of just saying that we have to think about EBV, as we know that that increases our risk of PTLD in our mismatched patients. Though it's not an infection that we can treat with antivirals, it is one that we should monitor closely and then be able to enact in terms of workup for PTLD. And then you all are experts on BK. Unfortunately, we have no treatment, no antiviral treatment that's been shown to be effective. We know that CTLs are still very much in development and unfortunately have not been proven to be very effective yet. And so it all comes down to reduction in immunosuppression. And then finally, the reason I left fungal infections at the end with just one slide is that we're fortunate, at least in our renal transplant patients, that we do not see a high burden of fungal infections compared to our liver and thoracic organ transplant recipients. But we can't forget about Candida and specifically mycotic aneurysm. If our donors have Candida growth in their urine cultures and or have been candidemic, but even just in their urine cultures, we know that leads to a higher risk of mycotic aneurysms, and those recipients should be treated with antifungal and not mycofungin because we wanted to have good urinary penetration, so should really be on high doses of fluconazole. The picture to the right is a renal transplant recipient, their graft with candidiasis at the time of autopsy, and the left is cryptococcus because we know that that is the next to Candida, the highest risk of reactivation in our patients. So we can't forget about their lungs, though we're so focused on their kidneys, of thinking, do they have something that they've been exposed to before that then a few years post-transplant they will reactivate and go on to having cryptococcal meningitis. And then finally, you might say that, well, what is missing from this talk is UTIs. I feel like we could talk about UTIs for hours and hours and none of us would be happy with it because there is no one thing with it. But I think the one thing I want to leave you with in terms of UTIs is that we have multiple studies that show that treatment of asymptomatic bacteriuria, even in our renal transplant recipients, is not warranted and is not recommended. And so that myth that we used to do many years ago, we should not be doing going forward. And fortunately, we have many data to show us that. All right. Thank you all so much.
Thank you for two great talks. We're going to round out the session with Dr. Michelle Lubetsky, who's coming to us from Dell Medical Center in Austin, Texas, and she'll be talking about how we might think about managing a failing kidney transplant.
All right. Hello, everybody. So Michelle Lubetsky, I'm from Austin, Texas currently, and I'm speaking today about how I treat a failing kidney transplant. I have nothing to disclose, and thank you so much to the committee for having me come and speak today. So hopefully, by the end of this talk, you'll have some idea of an improved understanding of the medical complexities of the failing allograft. You'll be able to identify opportunities to improve the quality of care for patients with failing allografts with a specific goal of reducing excess morbidity and mortality that's seen, especially as patients' allografts fail and they transition to dialysis. I'll show you the data there, but that's really a period of significant morbidity and mortality for our patients. And ultimately, what we want to do is identify opportunities to improve coordination of care between transplant nephrologists and general nephrologists. So in general, the number of patients who return to dialysis after a failed kidney allograft transplant is steadily rising. Return to dialysis once the allograft has failed is associated with significantly increased morbidity and mortality. Studies have noted that these patients, as they return to dialysis, have worse blood pressure control, more anemia, lower bicarbonate levels, higher phosphate levels when compared to patients who have not had a previous transplant. So not only do they have increased morbidity and mortality, the CKD management at this time period as they're transitioning to dialysis has been shown to be much less effective. So the goal really is to improve these transitions, and hopefully by improving this transition of care, we'll improve the health and wellness of our patients. So why? Why is this period so fraught with increased morbidity, mortality? Most of the data seems to show the increased morbidity is coming from infection-related deaths as well as cardiac deaths. Infection risk during this time has been shown to be much higher. Mostly these are rates with sepsis, and especially in patients who start dialysis with an indwelling catheter as opposed to more permanent dialysis access. We also tend to see a lot of cardiac risks, especially from patients who continue to be on high doses of immunosuppression that get continued after return to dialysis. And as I mentioned earlier, lack of dialysis access has been shown to be associated with increased mortality. So why, if immunosuppression is causing sepsis and cardiac complications, so why then not just take everybody off right away? So hopefully you'll see it is a balance that we're trying to create between reducing these risks of infection, malignancy, metabolic complications, but balancing that with the risk of sensitization. So we do know, and I'll show you the data, that once we take patients off their immunosuppression, their rates of sensitization increase significantly, so the ability to get a repeat transplant declines. So ideally, we need to find, and there is no one right solution for any particular patient in terms of this balance, but the goal is to find a balance between these two. So what are the major complications of long-term immunosuppression? Most of us probably know these, but I'm going to go through a few of them. Increased risk of mortality, infection, malignancies. So mortality after allograft failure has been shown to be in the first week after return to dialysis 13 times as high as in patients who do not have a previous kidney transplant. This actually continues through the first 6 months or so, but the mortality is really highest in the first week and the first month after allograft failure and return to dialysis. Infection-related hospitalizations or deaths are significantly higher compared to patients who've never had a previous transplant. There's many data that show increased risk of death due to sepsis, especially in the setting of indwelling catheters. And there still continues to be increased risk of malignancy in patients, especially those who are maintained on immunosuppression. So during transplant, we tend to see higher rates of viral malignancies from viral origins in addition to skin cancers. However, after return to dialysis, we still see higher rates of leukemia, lung cancers, kidney, urinary tract, and thyroid cancers. Tend to be cancers associated with end-stage kidney disease that those rates go up, especially if patients maintain immunosuppression. This study that was done, which discussed the rates of malignancy post-transplant, did not look at immunosuppression tapering. However, despite the risks of staying on immunosuppression, there clearly are some benefits. So risk of sensitization has been shown in multiple studies that once we remove immunosuppression, calculated PRA will increase. So the first study showed that patients who had a calculated PRA went from 13% pre-weaning to 40% post-weaning and 62% post-cessation of immunosuppressive medications. Again, the higher your calculated PRA is, once you return to dialysis, will reduce your chance of getting a repeat transplant. Another study of 119 patients showed that 56% of patients developed a panel reactive antibody greater than 80%, again decreasing their likelihood of repeat transplant in patients once they removed their immunosuppression. So again, overall, weaning of immunosuppression is associated with a much higher risk of sensitization. So now that we know kind of potentially some of the risks of staying on immunosuppression and some of the benefits of staying on immunosuppression, how can we actually do something that's going to make a difference in our patients? And I think the goal really is to better understand what we want to do to manage immunosuppression once the transplant fails, and the immunosuppression management we'll talk about is going to be a really personalized approach, and we'll go through that. And then the second piece of it is there's a lot of people, a lot of cooks in the kitchen who are trying to improve this transition between the failed allograft and dialysis. And how do we improve communication and come up with plans that work for our patients so it's not just transplant nephrologists managing it or general nephrology, but kind of a shared care plan that will help benefit our patients. So these are kind of the different things that we're juggling. Again, with the goal being a personalized reduction of immunosuppression once the allograft fails. So some of the balls we think about, or we want everyone to think about, is, are they a repeat transplant candidate? So a patient who is probably going to get a repeat transplant, they're probably slightly healthier. We want to avoid sensitization, so the sensitization data becomes really important, and we want to facilitate preemptive transplant. Patients who may have multiple comorbidities, and we see lots of complications of immunosuppression even prior to returning to dialysis. These are patients who may be less likely to be great candidates for transplant, and we really need to think about the potential negative side effects of keeping them on prolonged immunosuppression, even if there is another transplant in their future, because we may start to see some of those malignancy, infectious complications, and certainly progression of their atherosclerotic disease. What about if they have residual renal function? So if they continue to make urine, do we want to just stop their immunosuppression? This might put them at a greater risk for graft intolerance syndrome, which we'll talk about later. So these may be patients who we want to keep on some more immunosuppression for a little bit longer. And overall, kind of by looking at all these different factors in each of our individual patients, will improve outcomes during this transition period. So I was part of a work group, part of the American Society of Transplantation, Kidney and Pancreas Community of Practice groups, and we had what we called the CRAFT work group, kidney recipients with allograft failure, transitions of care. And that was really our goal, was like, how do we take all these things that we're juggling? How do we improve these transitions? How do we make physicians more aware of what the issues are? And can we come up with a protocol that people can follow, or guidelines, rather, to help decide which patients are right to continue immunosuppression, which we should stop, and how rapidly should we do that. So we really wanted to aim to define the failing allograft and the multiple steps in terms of how an allograft fails, and give management guidelines both to the general nephrology community and the transplant community. So first we started with a survey. It was basically done to get a sense of what are the current practices happening in our community and what are some of the gaps in care. So in 2019, we did this survey. We surveyed 196 adult kidney transplant programs, and about 40% responded, but this represented about half of all transplants done in the United States between July of 2017 and June of 2018. The overall centers that did respond had higher volumes of both living and deceased donor transplants, and also female transplant patients. But then when we looked at the demographics of the patients and centers that responded and didn't, in terms of age, race, number of repeat transplants, sensitized patients, or causes of end-stage kidney disease, there was really no difference. So between those who responded and those did not. So we felt that this was an adequate sample, and these are some of our findings. But let's see if this works. So we're going to ask everybody in the audience, poll the audience, what is your initial approach to reduction of immunosuppression in the failing allograft? I've never used this, so let's see. Let's see how it works. So consensus. Consensus may be good, consensus may not be good. No. So you're very similar to what we saw when we sent our survey out. Most people agree. Oh, go back? Oh, sorry, it was just one vote. See, nobody. All right, sorry. Active with 4, sorry. Okay, that's more like what we saw. We should have music play. All right, I think that seems to have settled. So now I'll show you what the rest of, so what our surveys showed was actually fairly similar, but I think by the end of the talk, you'll kind of see why maybe I like to say there's no wrong answer here, but maybe that there really shouldn't be a unified protocol is more like what I want people to take out of this. So about 70% of our responders said they'd stop the antimetabolite first. About 13% said there was no unified protocol. And I think I point that out. I do think most providers do stop the antimetabolite first, but I think it's an important point that there really is not a unified protocol. And maybe that's okay. It might not be a bad thing. It just gives us an opportunity to study what might be the right approach for one particular patient compared to another. But overall, what we did see was that more than half of providers felt there really was need for a more standardized approach to taper immunosuppression in the failing allograft. So then the next question we asked them is, what are the most important factors in the decision to taper off immunosuppression? And I think maybe they let you pick one more than one, how I set it up. But these were the things that we asked the participants. So how important was availability of a kidney donor, infection risk, frailty, development of sensitization, malignancy, age, cancer risk? And the way we actually set up the question was most important, somewhat important, not very important. So we can keep that in mind when I show you the actual kind of data we got back, but the goal is really to get a sense of what are the different things, and I told you the balls that I juggle when I think about managing immunosuppression. What are the ones that you're thinking about? All right, so I'm going to show the next slide. So very similar. Can we go back to it? Yes. So the top 3 were sensitization, availability of a donor, infection risk, and very similar to what the general population we surveyed. Most important, people seem to think availability of a donor, followed only by risk of infection and sensitization, which were also very high in terms of being ranked as most important by the people we surveyed. So, but not to say that a lot of people didn't find comorbidities, frailties, side effects of medication. As you can see, there's a lot of things that people are thinking about of, most important and intermediate importance when we, wonder what exactly do I do with my patient's immunosuppression. Other things we wanted to find out were gaps in care. So we asked a few questions about transition of care between, if you're a transplant nephrologist, how often do you or your team discuss the transition of your care from a transplant nephrology clinic to general nephrology with patients once their allograft fails? Well, great that half the people did, but that means there's a lot of people that actually really don't have that conversation. And I know practices tend to, I've worked in New York City, I've worked in Texas, practices in each place vary extremely widely and differently by center, by physician. Some transplant centers keep their transplant patients for life. Some send them out after a year. Some send them out somewhere beyond that or sooner than that. It really depends on the center and the practice of the center. So there's potential that some patients have been never seen by their transplant nephrologist after the first year, and a general local nephrologist is following them, and there's some who are constantly with the transplant center, and all that in between. But I think what this slide really showed us was that there's a lot of differing practice in terms of how much transition of care happens between the two centers and how much communication there is. We also said, we also asked the question, well, what happens if you're a transplant nephrologist? How often do you see a patient with a failed allograft once they start dialysis? And again, the responses were really interesting. Assuming that most of these patients are being weaned from their immunosuppression once they start dialysis, about a third said there was no protocol, about a fifth said they do a follow-up visit every 3 to 6 months until they're off their immunosuppression. And then there were a lot of people who either did one visit or no visits. So if you can imagine, there's definitely a significant number of patients where this is being done primarily by the general nephrologist. There's definitely some patients where it's a shared care model, and there's definitely some patients where the transplant providers continue to follow. So there's a lot of heterogeneity in terms of how different people approach this, which gave us the thought that there's a big opportunity to educate both sides of the community on how to manage this transition. So the next focus of our work group after we completed the survey was then to actually say, well, can we come up with guidelines? And I'll say guidelines in quotes because I think you'll see once I give you our suggestions and guidelines that they're really very loose. They're more about suggestions of things to think about and things to incorporate into your approach as the allograft fails. So the first thing we did as a group was said, well, let's take the definition of the failing allograft. So typically we all think, oh, the allograft fails. That means the patient returned to dialysis. They were put again on the wait list, or they received a repeat transplant. But we didn't feel like this adequately encompassed all the things that are really happening during this time period, because being on dialysis is very different than having a GFR of 19, which you may have a GFR of 19 for a year, and what you're doing with your immunosuppression in that setting is very different than once you're back on dialysis, and it's very different as your GFR declines and you get a repeat transplant. So while this is kind of the common definition of a failed allograft, it doesn't actually incorporate all the phases that happen, the multiple management phases that happen during this time period. Specifically, that consideration for repeat transplant, residual allograft function, anticipation, and timing of dialysis initiation. So our goal really was to create a proposal that defined allograft failure, so it's not just this resumption of dialysis or repeat waitlisting, but include all these phases of declining allograft function so that we could come up with strategies for immunosuppression, preparing for repeat transplant, and preparing for resuming dialysis. Again, the ultimate goal being to personalize care that meets the needs of our patients, no matter which one of these phases that they're at. And really what we want to do is improve rates of relisting, improve CKD management, which we know falls through the cracks in these patients, and hopefully ultimately reduce morbidity and mortality. So we came up with this three-phase definition. Phase one was stable but low allograft function, people whose GFR might be hanging out around 20. They may start to be seeing some side effects of immunosuppression with a low GFR, but what you're doing for them is probably going to be more of a maintenance of where they're at and try to protect their kidney function as long as possible. Whereas phase two is when we really start to see that irreversible and progressive decline in kidney function, where we anticipate that allograft survival will be less than 1 year. And then phase three is when they actually return to some method of kidney replacement therapy. And as we go kind of through these, you'll see that each of these phases, and whether they are or are not a candidate for repeat transplant, will have implications in terms of how we both want to adjust their immunosuppression or think about their immunosuppression, as well as their overall CKD management strategies. So how do we manage immunosuppression in a failing allograft? So this is a big slide with a lot of stuff on it. This was kind of our overall guidelines for management, and we divided it into those 3 phases, looking at stable transplant function, where the GFR is over 20, whether they have failing transplant with a declining function, and we anticipate that they will have allograft failure within 1 year, and then once they've returned to dialysis, and then we separated them into whether they were a candidate for repeat transplant or not. And we came up with goals in terms of both immunosuppression, but also in terms of the shared management plan between whether they're transplant nephrology and the general nephrology, so that patients were not just thinking about immunosuppression, but also managing their complications of chronic kidney disease in terms of anemia, blood pressure management, bone mineral disease health, and as well as thinking about sensitization. So in our patients with stable transplant function and a stable GFR, if they were a candidate for repeat transplant, this is when we want to optimize their CKD management, including blood pressure control, anemia, proteinuria, secondary hyperparathyroidism, continue routine malignancy surveillance, and close monitoring for potential side effects of immunosuppression, potentially targeting slightly lower goals, but for the most part, keeping them stable on their immunosuppression. If they're not a candidate for repeat transplant, this is when we want to, if they're not being followed by a general nephrologist, start to make sure that there's a joint care model happening, so that even if we're managing as a transplant nephrologist the immunosuppression, some of the CKD management, specifically dialysis education, teaching, and those discussions are being happened as well with the general nephrology team. For patients who's failing transplant and we anticipate within a year they'll need to resume dialysis, this is when we want to be more aggressive about getting them relisted for kidney transplant, establish a baseline PRA value. If they don't have a living donor, talk to them about programs such as living donor champions, which have been shown to, if you don't have an available living donor but you have someone that can be your advocate, been shown to increase opportunities for living donor transplant. They should be referred, even if they are a candidate for repeat transplant, to general nephrology to prepare for dialysis and potentially create access if we think they'll be on dialysis and they don't have access. And we can start to think in these patients, when the GFR dips below 20, sometimes we do tend to see more leukopenia from the antimetabolites. It may be more appropriate to maintain a lower tacrolimus trough if they have no prior histories of rejection and are not sensitized. So we may want to start to think about lowering overall immunosuppression. If they're not a candidate for repeat transplant, this is when we want to make sure 100% they're set up with a general nephrologist, they've discussed vascular access, they've discussed dialysis modalities, and we come up with a plan for adjusting immunosuppression once they return to dialysis. And then the last group is once their allograft has failed, this is when, again, that personalized approach comes in, because if they're a candidate for repeat transplant, I would advocate that there are some patients, if they're overall healthy enough, that maintaining them on a low dose of immunosuppression while waitlisted can be a successful way to keep their sensitization at bay. And I don't think there's a right answer whether it's a calcineurin or whether it is a low dose of prednisone. Typically, we will stop within the first 3 months the antimetabolite, maintaining a low dose CNI and prednisone. And then what happens over the next 6 to 12 months, whether we take them off everything or we leave them on either a low dose of CNI or a low dose of prednisone, will really depend on how soon we think they're going to get a repeat transplant, availability of a living donor, are they still making urine, and then also their sensitization. So to date, I have not seen any great studies that have looked at immunosuppression versus and following PRA and adjusting immunosuppression post starting dialysis. I just don't think people are that interested in studying it, but I'm interested in it. But I think there's no right tacro level or right prednisone dose, but I think if we can monitor their CPRA while they're back on dialysis on a low dose of immunosuppression and look for signs of increased sensitization, that might be one way to do it. I just don't think it's been studied that well. If they're not a candidate for retransplant, again, at this point is when the primary management will move to general nephrology. Immunosuppression should be tapered. The antimetabolite typically is stopped first in most patients, and then over time, the CNI can be tapered by 50%, and then somewhere again in the 6 months, plus or minus 6 to 12 months, to try to get everybody off immunosuppression. Done more rapidly in patients who've seen more complications from immunosuppression, done much slower in patients who develop graft intolerance or rejection of the retained allograft. I'm gonna skip that next one in honor, just to keep moving. So who gets an allograft nephrectomy? So I mentioned graft intolerance syndrome. So this is a common clinical finding where patients, as we reduce their immunosuppression, might develop fever, hematuria, the allograft can become enlarged, edematous. We also may see more subclinical, not subclinical, but not as gross manifestations in the sense that they might have ESA-resistant anemia, they might have thrombocytopenia, elevated inflammatory markers. Typically, we start to see it as patients reduce their immunosuppression. So how do we decide when to remove the allograft? The benefits of nephrectomy really need to be weighed against the risks of the procedure. There is evidence that removal of the allograft generates more donor-specific antibodies independent of immunosuppression withdrawal. Oh, 1 minute? Oh, this is 25. Okay, sorry. Okay. I'll keep moving. So this slide really sums it up. PRA does go up after immunosuppression withdrawal. So you can see graft in situ. Pre-immunosuppression withdrawal is the white. Post-immunosuppression wean is the gray, and black is once immunosuppression's been stopped, and it's comparing those with nephrectomy without. Typically, once patients, the first time they have graft intolerance syndrome, we'll treat with steroids and then slowly taper immunosuppression after that. Nephrectomy is usually if they've failed medical management. I've mentioned this before, so I'm going to go a little quickly. Again, returning to dialysis. If you have a lack of an AV fistula associated with an increased risk of all-cause death, as well as an increased risk of sepsis. And some of the, in addition to following up with general nephrology to create access, discuss dialysis modalities. Some of the data has shown that there's something called low clearance transplant clinics where once the GFR reaches less than 30, having a care team that really is focused on looking at discussing return to dialysis, discussing access placement, having special renal dietitians to really help this transition has shown patients to feel better about their counseling and get more patients evaluated for repeat transplant. Evaluation for repeat transplant is very important. Assuming patients are a candidate, they should get evaluated as soon as possible. Unfortunately, less repeat transplant patients are being listed and less are being retransplanted. Some of the barriers to relisting are things that we might expect. Patients less likely to be relisted are African American, Hispanic, males, older, obese, publicly insured or have lower education, were diabetic or had longer dialysis time prior to initial transplant. Very similar in terms of who's getting a preemptive kidney retransplant also is less likely to happen in less educated Black race and males. But overall, the data does show significant benefit to patients who do get a repeat transplant, especially in the 18 to 59 year age group. And this data essentially shows that within the first 4 years of graft loss, getting a repeat transplant has significant survival benefit. Much beyond the 4 years since graft loss, the survival benefit disappears. So. Conclusion. Sorry about skipping through those, but the slides are available if anybody wants them. Two things we really want to focus on: immunosuppression management goals and transition of care goals. So our goal really is to come up with a personalized weaning approach, really to minimize sensitization for patients who are repeat transplant. However, patients who may not get a repeat transplant, minimize the risks of prolonged exposure. So there's no one right way to do it. I think the answer is as slow as tolerated, and to keep in mind things like sensitization and be checking in on that as your patients who may maintain immunosuppression as they wait for their next transplant. And then conversely, for patients who cannot receive another transplant, really be attuned to potential side effects from maintaining on these medications with a goal, if there's no repeat transplant, and getting everybody off within the first year. And then in terms of transition of care, because we are seeing less patients listed for retransplant, really important to try to discuss preemptive listing, offer transplant to all patients who are candidates for repeat transplant. If they're not, timely discussions and counseling on access, placement, and dialysis modalities, and overall creating more of a shared care model between general nephrologists and transplant nephrologists so that we minimize complications of CKD that happen as a transplant allograft fails. Thank you.
All right, so with that, we'll close the session. Thank you for your attention. Thank you for all, to all our speakers.